OCT by Dr. Amar Pujari and co-authors from Dr. R.P. Center for Ophthalmic Sciences. Our first case is a 44 years old female with posterior polar cataract. Here, we demonstrate the hydrodelineation with real-time intraoperative OCT. The first wave of hydrodelineation produces a golden ring and successfully separates the nucleus and the epinuclear plate. Another attempt of hydrodelineation is made just peripheral to the first golden ring, but well away from the equator. This second wave of fluid is seen to pass closer to the posterior capsule. In the replay, we can see that this second wave creates a fluid pocket at the posterior pole, thus endangering the posterior capsule. But thankfully, the posterior capsule remains intact. Our second case is another posterior polar cataract. The OCT image demonstrates the epinuclear cortical junction and the posterior polar cataract. Here, a single attempt of hydrodelineation is successful and the posterior capsule remains intact. In our third case, we demonstrate hydrodissection in a posterior subcapsular cataract. We insert the cannula just underneath the capsular axis margin and go close to the equator to inject balanced salt solution. The hydrodissection is successful. In the replay, we can see that the hydrodissection begins at the posterior pole of the lens. The maximum distension is produced at the posterior pole and then the dissection proceeds from center to the periphery of the lens. Further injection distends the capsular bag and pushes the lens matter upwards. In our fourth posterior polar cataract, we can see that the hydrodelineation is successful, but it has caused a break in the posterior capsular plaque. Some fluid can be seen behind the plaque, but the posterior capsule remains intact. In our fifth case, while attempting to perform hydrodelineation, some hydrodissection takes place. This can be seen clearly as a pocket of fluid between the cortex and the posterior capsule. After successful phacoemulsification of the nucleus, we can see that the posterior capsule is intact. Section first creates the maximum tension at the posterior pole and thus is contraindicated in posterior polar cataracts. In these posterior polar cataracts, even the routinely performed hydrodelineation may produce tension at the posterior capsule just beneath the plaque. Thus, in these cases, even hydrodelineation should be performed with caution.
So, nice video, and I wanted to ask you, like, based on what you kind of gleaned from this study. Now, everybody will not be able to afford a intraoperative OCT, and but what would you recommend based on this, that for your hydrodissection, like in which cases clinically would you prevent this kind of a blowout from happening, and where to suspect? Is there something else we can do? Can we use the UBM? Can we do something else? Because OCT helps you understand how it happened, but
yes, sir.
Any conclusions?
We
on
have
this?
a total series of 120 cases of postopolar cataract, sir. So one thing we described as a conical sign in preoperatively how to see the posterocapsular deficiency, that is under review in JCRS, sir. We have another 100 cases on CASIA 2 OCT, which is like similar to UVM, which is able to delineate the posterocapsule. Again, we are going to describe 3 signs of posterocapsular deficiency, sir. At the same time, we did 12 cases of IOCT guided hydrodelineation, sir. Hydrodissection is generally contraindicated, and we saw what is going to happen to the how the nuclear suppression is happening between the nucleus and the epinucleus, and what is that like how the capsule and the plaque is going to behave during hydrodelineation. We don't know, sir. So we wanted to see using real time. So in some cases, we saw that even simple hydrodelineation can cause inadvertent hydrodissection. So you should be judicious. If you are not able to see the golden ring, probably fluid has gone behind the plaque. That is one thing, sir. Second thing is you can see in the 4th case there was a fracture of the plaque or the posterior cortical opacity. So that can happen. If you are seeing that one, again you should be judicious. There might be opening of the capsule. General ophthalmologists may not be aware, but here you can see, sir.
Dr. Milind, would you like to comment on this? Whether this is actually going to be useful in kind of translating into some benefit for us?
So the key problem to define, let's think of it that way, is there a way of predicting which capsules will create problems for you before you start surgery? So that's the first question to ask yourself. And the question then comes, okay, would a preoperative OCT or anything like that help us in identifying those patients where we have problems?
Yes.
Now, it's beautiful video. It's a
Thank
great way of understanding what's going on. But in terms of the surgical strategy, what are you recommending? That we don't do hydrodissection, we don't do hydrodelineation?
We routinely don't do hydrodissection, sir, but hydrodelineation should be judicious. That is our recommendation.
So what do you mean by judicious? It means you shouldn't break the posterior capsule.
No, sir. If you are able to do, if you are able to see the golden ring, probably a proper hydrodelineation has happened, so you can
Okay.
take out the nucleus.
So if you get a golden ring, would it allow you to predict that patient where the capsule, the hydrodelineation leaked into the hydrodissection space?
So we didn't see in 12 cases, sir. That can happen. We are extending this observation. We have submitted 12 case series to JCRS as original
No,
article.
the question is, will it allow you, if you see a golden ring, are you happy that the posterior capsule is not ruptured?
In our 12 cases, we didn't see any rupture, sir.
Okay. In the other cases, in our cases, sorry, I'm not being difficult. I'm just trying to question the whole thing.
We are going to extend the study for deficient posterior capsule, or we are going to observe it further.
Okay.
So if there is any sign for in
It's,
future.
it's a great video, and I think
Thank
it's important to understand all the mechanisms of this. So congratulations.
Thank you.
Thanks.
Thank you, Ken. Thank you. Deepak, can we have you? Yes.